What's up, future doctors? Welcome back to Medical Notes Hub, the channel that turns your thickest textbook chapters into notes you'll actually remember on exam day. Today we're breaking down differential diagnosis of bronchiectasis. If you see coarse crackles plus copious sputum plus clubbing in a stem, your brain screams bronchiectasis. But examiners know that, so they twist it. Today, 6 differentials that mimic bronchiectasis, and the one detail that separates them every single time. We're splitting this into unilateral versus bilateral, because that's literally how the exam narrows it down before you even read the history. Unilateral bronchiectasis mimics resolving pneumonia, lung abscess, tuberculosis. Bilateral bronchiectasis mimics diffuse parenchymal lung disease, chronic pulmonary edema, cystic fibrosis. Let's study differences of them in detail. In bronchiectasis, long history of recurrent infection in the same lobe, chronic productive cough, copious purulent sputum, fever during exacerbations, hemoptysis may occur, persistent coarse crackles, clubbing common. In resolving pneumonia, recent acute pneumonia treated with antibiotics, cough improving, sputum small and becoming less, fever settling, hemoptysis uncommon, fine crackles that gradually disappear, no clubbing. Exam pearl. Persistent coarse crackles after repeated infections favor bronchiectasis. In lung abscess, sudden illness after aspiration, acute severe cough, copious foul-smelling sputum, high swinging fever, chest pain common, localized crackles with cavity signs, patient looks toxic and ill. Exam pearl. Anaerobic bacteria in lung abscess produce that putrid sputum smell. That's your giveaway word. In pulmonary tuberculosis, history of TB contact and weight loss, chronic cough, sputum bloodstreaked, night sweats common, evening rise of temperature, apical crackles, clubbing rare. Exam pearl. Weight loss plus night sweats strongly suggests TB. In diffuse parenchymal lung disease, occupational exposure or autoimmune disease in history, dry cough, progressive and prominent breathlessness, minimal sputum, fine end inspiratory Velcro crackles, clubbing also common, wheeze usually absent. Exam pearl. Dry cough plus Velcro crackles points toward DPLD. In pulmonary edema, heart failure history, orthopnea and paroxysmal nocturnal dyspnea, frothy pink sputum, raised JVP, leg edema present. Exam pearl. Orthopnea plus raised JVP suggests pulmonary edema. In cystic fibrosis, childhood onset, family history often positive, thick sticky sputum, plus steatorrhea, salty sweat, male infertility, clubbing crackles and malnutrition on exam. Exam pearl. Salty sweat plus pancreatic insufficiency strongly suggests cystic fibrosis. Quickfire, I say the clue, you say the diagnosis out loud right now. Foul-smelling sputum plus high fever, lung abscess. Weight loss plus night sweats, TB. Dry cough plus Velcro crackles, DPLD. Orthopnea plus raised JVP, pulmonary edema. Salty sweat plus steatorrhea, cystic fibrosis. If you got all 5 without looking, you just outperformed most final years. That covers everything you need for your exams on this topic. Drop your questions in the comments, subscribe for more high-yield content, and good luck with your studies. Medical Notes Hub out.